I'm doing a presentation with Amanda Melton and Temper Goff on therapeutic hypothermia after cardiac arrest. Our objectives today with this presentation are basically we want you to be able to state what therapeutic hypothermia is, and also to be able to state the indications for doing this procedure on a patient after cardiac arrest. Also, we want you to be able to state the effectiveness of therapeutic hypothermia post-cardiac arrest, and to know what nursing responsibilities and interventions are involved in caring for a patient during and post this procedure. So basically we want to start out first by outlining what cardiac arrest is. So basically cardiac arrest is when the heart's electrical system stops working, so your heart stops pumping blood to the extremities, and so it results in the abrupt loss of heart function. So the cause of cardiac arrest are basically you have dysrhythmias or anything that's affecting the electrical system of the heart to make it basically stop conducting and stop pumping blood with a pulse. So systemic death occurs within minutes of the heart stopping unless immediate action happens. So basically this patient's going to die unless you initiate CPR or some kind of defibrillation, or a code team comes in and takes immediate action on this patient. So the most common cause of death during a cardiac arrest is neurological injury. So basically this patient's brain stops functioning because of tissue damage, because of the lack of oxygen and perfusion to the tissue in the brain. So basically what we're looking at is why do we initiate hypothermia when a patient's going and having these symptoms. Okay, so basically the definition of therapeutic hypothermia is cooling the body's core temperature to 33 degrees or 91.4 degrees Fahrenheit after the incident of cardiac arrest. So why do we do this procedure? Basically, because the main issue of cardiac arrest is a neurological injury, we want to protect the brain from the deoxygenation that's going to occur and the damage that can happen because of that. So putting a patient into hypothermia basically is going to decrease the metabolic rates within the cells, all of the cells of the body. And this occurs in the brain too, so the oxygen demands of the brain are less. So when not as much oxygen is being able to be pumped to the brain from the heart because of the cardiac arrest, it's going to create that to not be as severe of a process when the blood comes back in. Because reperfusion injury is what's causing this tissue to become damaged. So reperfusion injury occurs when the blood is too quickly reintroduced to an area of previous ischemic tissue, like the brain, causing the tissue damage.
Now let's talk about the patient criteria for inducing this to a patient. First of all, the patient has to be unresponsive and survive the cardiac arrest, because you can't perform this on someone that's already dead. Secondly, you have to do it within the first 6 hours of them coming back after a cardiac arrest, because after the 6 hours is when the majority of the tissue damage has already been done. Lastly, you cannot do this on patients that already have a DNR because it's prolonging their life, and most people that have a DNR do not want to have prolonged life. Plus, it's after a cardiac arrest, and they didn't want to be resuscitated in the first place. Secondly, you cannot do it on a patient that has an active hemorrhage because they have a prolonged PTT time whenever you induce them in a hypothermic state. And so if they're already bleeding really fast, then they're not going to be able to, they're just going to bleed even more. There's different ways of cooling the patient down. The first way is surface cooling with ice packs. And basically that's where you take a bunch of ice packs and you put them in the places that have the largest heat exchange capacity, such as like your neck, your head, your axillary, and your groin area. And once the ice is melted, you just basically repack them again with a bunch of ice. Secondly, you have the surface cooling with blankets, or the surface heat exchange device and ice. And this is where you place the patient in between two blankets, cooling blankets, and you pack ice around them. And then once the ice is melted and they've reached the therapeutic state of the therapeutic temperature, you remove the ice and you just leave them in the blankets, therefore keeping them at that cool state and everything. You also have a surface cooling helmet, which is like a bonnet, and you just basically put it on their head, and it's filled with cool aqueous gel that helps keep their head cooled. You also have internal cooling methods using catheter-based technologies, and this allows for heat exchange between cooled saline that passes through the heat exchange portion of the catheter, which is a cooled, large surface area for heat exchange, and the blood that flows over the outer surface of the catheter allows for that heat exchange to occur. These ways help to maintain them cool or rewarm them. For example, if they get too cold, you can rewarm them a little bit because this allows for them to be warmed up a little bit. Or if they get too warm, you can cool them back down even more. So it allows for them to go both ways. Lastly, you have the internal cooling methods using infusion of cold fluids. And the typical infusion volume is normally 30 milliliters per kilogram or 2 liters of fluid using either normal saline or lactated Ringer solution. On the next couple of slides, we have pictures. This is a picture of one of the machines that uses fluids and cools them down and everything. And then this is the catheter that's used with it that goes in there. And then this is the Arctic sun. And we have a picture of it being used in the next slide. And see, it just cools the fluid and it takes them through these cooling blankets, and then it allows the fluid to go back and forth, and that way you can monitor the patient's temperature and everything using that. Now Amanda's going to talk about the effectiveness and the nursing interventions that needs to be used.
Talk a little bit about the effectiveness of this treatment. We all talk about evidence-based practice and how that affects how we treat our patients. There have been several studies done over this, but however, there's been no study to really say that this actually works. So with that being said, different studies that say different things. There are some studies that say, yes, this is effective. There are other studies that say, no, this isn't effective. But most recent studies have shown that this really doesn't affect patient outcomes all that much. This recommendation, though, is still held by the American Heart Association and International Resuscitation Guidelines. They do still recommend that we do the hypothermic treatment for patients. Some adverse effects that can happen as a result of making a patient hypothermic is, of course, shivering. That's your body's response to trying to warm itself back up. And in order to counteract this, we usually give patients propanol and fentanyl, as well as a neuromuscular blocker to kind of sedate them and help stop that shivering process. Also, you need to watch out for coagulopathy. Another problem you can have is coagulation problems. Anybody that's hypothermic has an increased PTT time anyways, so you're going to want to monitor this patient to make sure they're not having any kind of internal or external bleeding. You're also going to want to monitor the patient for cardiac arrhythmia as a result of being hypothermic. Also, hyperglycemia can be a big problem, especially with all that stress on the body of everything that's happened. You're also going to monitor the patient for sepsis or any kind of infections, since they're at a decreased metabolic rate. And another thing is, since they have a decreased metabolic rate, is you're going to want to monitor them and their drugs that you're going to give. You'll probably have to decrease the doses accordingly based on their metabolism. And the last thing that you want to monitor for is electrolyte imbalances, especially hyperkalemia or hypokalemia, and just continue to monitor their cardiac status. For nursing interventions, the number one thing that's important is that you continue to monitor that core body temperature. And this is just to ensure that the patient isn't getting too hot or too cold for the therapy. And the gold standard to measure this is through a central venous catheter. However, if you don't have access to that or they're unable to access that in the patient, then you can also obtain the temperatures through esophageal, bladder, and rectal temperatures. We're going to continue to monitor the blood pressure in this patient, preferably through an arterial line if it's available. And you're also going to place the patient on continuous telemetry and monitor their heart rate and rhythm just to make sure that they aren't having any kind of dysrhythmias as a result of the hypothermia. And then you're going to determine their MAP goal. Usually this is determined or set by the doctor, and continue to monitor them and make sure they're meeting that MAP goal. And then you also want to keep the head of the bed raised at least 30 degrees. To continue with the nursing interventions, of course, skincare should be provided every 2 to 6 hours at least. You're not going to provide the patient with nutrition during this time because the decreased metabolism, and also you don't want to put the extra stress of the body having to metabolize food during this time. Some hematologic testing, your lab tests that you want to look for are your CBCs, your troponin levels, your PTT times. Look at for your complete metabolic panel to monitor their electrolytes and their glucose, as well as a few other tests. And then I'm going to talk a little bit about rewarming the patient. Obviously, you don't want to keep the patient in a hypothermic state for too long. So usually we begin rewarming them 24 hours after we start the cold therapy. You do this very, very slowly. You don't want to warm them up more than 0.5 degrees Celsius an hour. And it takes approximately 8 hours to warm the patient back up. To do this, you want to remove the cooling measures very slowly. You don't want to take off too many cooling blankets or take the therapy off completely or stop the infusions completely. You want to do it very slowly. You're also going to maintain the patient's sedation until their core temperature reaches 35 degrees Celsius. It's very important so that way they don't shiver and put themselves back into another state of hypothermia. And you're going to monitor them for hypertension, and you're also going to stop any kind of potassium infusions or any kind of electrolyte drips that they have going. And for family education, you're going to obviously want to tell them that if the patient is a DNR order, we cannot do this because this is a resuscitation method and we can't resuscitate a patient that's a DNR. You're also going to educate the family about the possible adverse effects that can happen as a result of putting the patient into hypothermia. And you're also going to explain the procedure to the patient or to the family and explain why we are putting their loved one into a hypothermic state. And of course, you're going to provide emotional support to them. And we have our references here. Thank you, and if you have any questions, please feel free to email us or contact one of us.
Let's kick it.